wọ́n ní mo rí nọ́mbà kan tó pè mí. Mi ìwà well dressed ẹni.
Good evening, all. You are welcome. Thank you very much for joining this early. We won't wait. We'll start so that others will join us. Thank God it's recorded in YouTube. People can always go there and listen so that it won't be nice to keep our resource person waiting for people to join. We'll start. They will join us along the line. So, Dr. Edemi, you have the floor. Let's start.
Good evening, sirs and mas. Happy Sunday. Please, am I audible?
Yes, very audible.
Okay, so we are all welcome to today's Zoom meeting. And today, I'm delighted to be ushering in our teacher, our trainer, who will be discussing the topic hypertension in pregnancy. So I would want all of us to pay attention, write down our questions, and at the end of the teaching, we can now go ahead to ask our questions. So I'll be ushering in Dr. Similoluwa Oluwafunmilayo Albert. She's a consultant obstetrician gynecologist at Eco Hospital, and she'll be taking the topic hypertension in pregnancy. You will all agree with me that it's a very essential topic. It's very pertinent in our management, even as a GP and as specialist. So without much ado, I would like to welcome her on board, ma. Good evening, ma.
Good evening, everyone. I hope you can hear me.
Yes, we can hear you.
Am I audible? Okay, guys.
You are audible, ma.
So, okay, ma. Good evening. So my name is Similoluwa Albert, as I've been introduced, and I'm a consultant obstetrician gynecologist. I really want to appreciate Dr. Olajujoye and the team for this vision of enlightening both the caregivers and the patients on important health issues. Thank you also for giving me the opportunity to be part of today's discussion. And today we'll be looking at a very important topic, hypertension in pregnancy. I know we have looked at hypertensive diseases in different groups of people, but today we are looking at these special people because it's not only the woman that we are looking at, but we are looking at the fetus inside the woman. So I'll be spending most of the time on the type of hypertension that is unique to pregnancy, which is hypertension you cannot have without pregnancy. And I prepared the discussion in such a way that each type of hypertension will be discussed from definition to management. This is because the definitions are different. And the basic thing is that with the basic thing with all of them is that the blood pressure is from 140 systolic to and above, then 90 millimeters of mercury for diastolic and above. So that's the only thing that is common with them. So as we go on, I know we will get to know what happens. So hypertension is a disease that is very rampant now. And in pregnancy, there's a way blood pressure actually is in pregnancy. In a normal pregnancy, blood pressure typically decreases slightly in the first half of pregnancy. That's in the first 20 weeks. Then it will reach its lowest level between 22 to 24 weeks. Then it will start picking up to be rising until it now becomes the pre-pregnancy stage after delivery. So today we are going to take the types of hypertension disorder in pregnancy. There are 4 types. They are divided into 4. The first one is chronic hypertension in pregnancy. Then there is gestational hypertension. The third one, eclampsia. Then the last one is pre-eclampsia superimposed on chronic hypertension. Now we go to chronic hypertension. Please let my slide be changing, doctor. Next slide, please. So chronic hypertension in pregnancy, by definition, this is high blood pressure that precedes pregnancy. That means that it is already existing in that woman before she got pregnant. And another thing is that it is diagnosed within the first 20 weeks of pregnancy. Then the third description is that it does not resolve by the 12-week postpartum checkup. You know, the problem with the people in our environment is that they tend to book for antenatal late. And most people don't even check their blood pressure or anything, or even health check. Some people is in that pregnancy that you will know that they were hypertensive before the pregnancy. Because most people will come and book when they're already 12 weeks, 20 weeks and above. And that is the time that we have the lowest blood pressure. And when we are picking the patient at that level, we might look at it that the blood pressure is normal, whereas it is not normal because it is already at the lowest level. So this chronic hypertension in pregnancy complicates 5% of all pregnancies. And its prevalence tends to be increasing now. And the main thing that's accounting for this is because people tend to delay childbearing. A lot of women, they want to let them be financially stable before they start having children. They have to have work. They want to be financially okay, have their job, finish all their career and everything before they start thinking of childbearing. So it tends to make them to be of advanced age before they start having their babies. Now, chronic hypertension is divided into 2 types. There's mild and there's severe. Mild chronic hypertension is blood pressure ranging from 140 systolic and 90 millimeters of mercury diastolic to 179 millimeters of mercury over 109 millimeters of mercury. Then the severe is anything that is equal and above 180 millimeters of mercury systolic over 110 millimeters of mercury diastolic. Most of the times you realize that these patients will not have any symptoms. In fact, because they're already used to being hypertensive, they might not even have anything that can show that there's a problem. So the only way we can know if they're hypertensive is by checking the blood pressure. So, and at times they can just give mild complaints, like maybe they were not sleeping well and things like that. So, for the chronic hypertension, the first thing after diagnosis is to review the drugs that these patients are on, because some of them they were not even, they might even say that the patient, they were not prepared for the pregnancy. So most of the medications that they are using before pregnancy might not be the medication that is safe in pregnancy. So their medication has to be reviewed, and after we have reviewed it, it has to be converted to the ones that are safe in pregnancy. And the antihypertensives that have been widely studied that is safe in pregnancy have been alpha-methyl dopa, popularly called Adomid. And this is the first choice in pregnancy. So if patient is discovered to be hypertensive and is pregnant, one thing you want to do is, okay, let's convert to maybe methyl. And it is most studied, and also it has limited effect on uteroplacental blood flow. So another antihypertensive is labetalol. Labetalol, this is combination of alpha and beta blockers, and is the first alternative to methyl dopa. because it is well tolerated, and it also has very easy twice a day dose, unlike alpha methyldopa that will be changing at times you might say, okay, let's give 250 milligrams, let's give it 3 times a day, or you start saying, okay, let's give it twice a day, but this one is very specific. It's given twice a day. The other one that is used is channel blocker, the partial channel blocker. And this has become popularized because of its effect in helping with preterm labor. It serves as tocolytic. So because of that, it is very good. It is a thing that most doctors now run to go and use when there is high blood pressure. So diuretics have been used in pregnancies despite the theoretical risk of preventing normal blood volume expansion. But this is not a common medication that one uses. There's always a special indication that can make one to say, let's give diuretics. There are complications that can arise as a result of chronic hypertension. And one of these is that there is increased risk of superimposed preeclampsia. So people that have chronic hypertension, one thing that they are monitored for closely is preeclampsia, which is the fourth category of hypertensive disorder in pregnancy. Then they tend to have prematurity. It's not that maybe preterm labor just starts, but most of the time when you realize that this blood pressure is not getting controlled, and with that it means that the outside is better for this baby than inside. So one has to weigh the risk and the benefit of prematurity and having the baby to come out immediately so that there won't be intrauterine fetal death. So prematurity is a complication. Now, let's go to gestational hypertension. Okay, there are still some other complications. Please, let's go back to that slide. The slide before this one. Yes, we have small gestational age or IUGR because usually the blood flow, the placenta perfusion is reduced in hypertension. So babies' growth tend to be below what is expected for the age group. Then there is placenta abruptio that can happen as a result of high blood pressure. Then there is high rate of cesarean delivery and intrauterine death. Now, rates of complication are directly related to the severity and duration of elevated blood pressure, meaning that how long the blood pressure has been persistently high and the level will determine how much of complication the patient will experience. Then patients undergoing increased surveillance, yes, because of this high blood pressure, they tend to need to have increased high surveillance. They are high risk group, so a lot of things have to be done to prevent everything that can make them to have complication. And at every point that it's better for this delivery to happen, it will now go ahead to happen. So the goal is to deliver the baby vaginally, but anytime that there's an indication for cesarean section, we don't hesitate to do that. Next slide. Next one is gestational hypertension. Gestational hypertension, this one is one that has been called different names. It's called transient hypertension of pregnancy. It's called chronic hypertension identified in the later half of pregnancy. And it used to be called pregnancy-induced hypertension. But that terminology does not work because of all the things that happen. So now it is transient because it is just during the hypertension starts at the second half of pregnancy. That's from 20 weeks and above. That is when the high blood pressure is discovered. Then the patient previously noted to have normal blood pressure, and there's no protein in the urine. So meaning there's no proteinuria, no manifestation of preeclampsia or eclampsia. This diagnosis most of the time is retrospectively made. It is after the patient has delivered, and even after you have had the 12-week postpartum basis and everything is normal. That's why we now say definitely this one is gestational hypertension. Next slide. Now, the diagnosis of this hypertension involves very increased surveillance, because like 50% of the women diagnosed with gestational hypertension between 24 and 35 weeks tend to develop preeclampsia. So as soon as gestational hypertension is diagnosed, we have to continue to screen the patient, to monitor closely, so that at any point where preeclampsia is coming up, it will be tackled. Those that progress to severe gestational hypertension based on degree of blood pressure elevation are worse, have worse perinatal outcome than do women with mild preeclampsia. So such people and those those that have severe preeclampsia, meaning that once the blood pressure reading of gestational hypertension is very high, you just take them as preeclampsia. Don't wait until there is proteinuria. So treatment is, as we have discussed, under chronic hypertension, as in the medications. Now, the next one is preeclampsia, eclampsia. Preeclampsia, eclampsia. This is a disease that is called sickness of theory. Sickness of theory. So please, next slide. Preeclampsia is a multi-organ disease process. It has unknown etiology. That's why it's just a disease of theory, different theories that one can say, okay, this is what is causing this. It is characterized by development of hypertension and proteinuria after 20 weeks of gestation, meaning that these people, they were not hypertensive at all, but the hypertension starts after the second half of pregnancy, and there's also proteinuria. There are risk factors for preeclampsia, and these are antiphospholipid antibody syndrome, chronic hypertension, chronic renal disease, elevated body mass index. So when we talk of obesity and everything, then maternal age older than 40 years, multiple gestation, nulliparity, then past history of preeclampsia and pregestational diabetes, and also multiparous patient that is having the first pregnancy for a new spouse, a new partner. That also is a risk factor. Next slide. So the theories concerning the pathogenesis of preeclampsia, there's this one called two-stage model, and it tends to be the popular one that is being adopted. Normally, during a normal pregnancy, fetal syncytial trophoblast penetrate and remodel maternal spiral artery, causing them to dilate into large plastic vessels. This remodeling accommodates the vast increased maternal circulation needed for adequate placenta perfusion. This remodeling is somehow prevented in the okay, sorry, I'm back now.
Okay,
So
ma.
the two-stage, okay, thank you. The two-stage modeling, the first stage is impaired placentation and reduced perfusion. As we have discussed that in this preeclamptic patient, the normal thing that's supposed to blood breastfeed didn't happen. So this one is impaired and abnormal trophoblast invasion opens, and other factors like could have happened, especially with those people that have chronic hypertension that now have stage. The second stage is the one that there is reduced placenta perfusion, which leads to release of factors from the placenta that enter the maternal circulation and causing widespread damage to the lining of blood vessels. This dysfunction now manifests as hypertension, which is due to increased vascular resistance and vasoconstriction. Then proteinuria happens due to leakage of protein into the urine, and multi-organ damage. Kidney, liver, brain, and coagulation abnormalities now happens. So that is the other theories like immune tolerance, oxidative stress and inflammation, genetic factors, cardiovascular, they are all other theories that are being proposed. Now, diagnosis of preeclampsia is made with elevated blood pressure after 20-week gestation of equal or greater than 140/90 millimeters of mercury that is taken at least in 2 measurements of 6 hours apart. Then proteinuria of greater or equal to 0.3 grams per 24 hours. That is 300 milligrams in 24-hour urine. That is another another means of diagnosis. Next slide. So there are two types of preeclampsia. There is the mild preeclampsia. The blood pressure here ranges between 140/90 millimeters of mercury to 159/109 millimeters of mercury. And the proteinuria is from 0.3 grams to less than 5 grams per 24 hours. While severe preeclampsia is blood pressure of 160/100 millimeters of mercury and above, and proteinuria of greater or equal to 5 grams per 24 hours of urine. And this is greater or equal to 3 pluses of protein in urinalysis, which is taken on 2 random samples of 4 hours apart. So manifestation of end organ diseases is also part of severe preeclampsia. Then hematologic changes, hepatic changes, neurologic changes, renal changes, placenta abruption, when all these ones accompany preeclampsia, then it is severe preeclampsia. There's a time that they used to talk of imminent eclampsia. That's when preeclampsia is becoming symptomatic. You're having blurring of vision, you are doing different things like that. Then we now say imminent, they are all severe preeclampsia. Okay. Next slide. Now, there is usually abnormal Doppler waveforms in Doppler examination of patients with preeclampsia. So with that one can even suspect that this is preeclampsia. Normally, in the Doppler, the ratio of forward flow of blood in the umbilical artery during systole to that during diastole, that's the umbilical artery, systolic ratio of systolic to diastolic ratio. This is used to assess the degree of resistance to flow in the placenta. The higher the ratio, the less diastolic flow, the greater the resistance to flow. Then the greater the peril to fetus, meaning that the higher the ratio, the systolic over diastolic ratio, in Doppler. The higher it is, then the more the resistance to perfusion and the more jeopardy the baby is. Then another thing that manifests as severe preeclampsia is Rett syndrome. There was a time that Rett syndrome used to look at as a different entity, but it is part of severe preeclampsia. It actually occurs in 20% of severe cases. Management of preeclampsia, the mainstay of treatment is early detection, because once it is detected early, all the things that needed to, the surveillance and everything that's supposed to be done can be done early. Then manage delivery. The decision to deliver involves balancing the risk of worsening preeclampsia against those of prematurity. When preeclampsia is diagnosed at term, it is easier. All that needed to be done is let's deliver, because once placenta is delivered, everything, there will be the problem with that will resolve. Now, mild preeclampsia, you manage those to term, but please don't go beyond the EDD, no matter how mild the preeclampsia might be. If you are able to manage the patient, don't go beyond 40 weeks, which is the EDD that we usually give to patients. Next slide, please. Okay. So where there's usually problem is when there is preeclampsia diagnosed remote from term. So, and when we have this kind of cases, we need to evaluate on admission. We admit for evaluation. We do all the baseline and serial laboratory tests, where we'll be able to pick, is it still mild? Is it still severe? How is it progressing? Then ultrasound for fetal growth and amniotic fluid volume. Then we look at the Doppler ultrasound that can also show us if baby is in jeopardy and needs immediate delivery, or we can still buy some time. Then non-stress test will assist. Biophysical profile, once it's done, and that can help us to monitor the 24-hour urine protein. The goal of treatment is to prevent seizure. That's to prevent eclampsia. And how this one is done is by using magnesium sulfate. We still talk about magnesium sulfate use when we discuss that one under eclampsia. But we use magnesium sulfate in severe preeclampsia to prevent seizure. Then we lower the blood pressure by using antihypertensive medication. And the next thing is to make sure that delivery takes place as soon and as safe as it's possible. So for fetal long maturity, maybe the patient should be given corticosteroids. And once they are taking the corticosteroid for between 12 to 24 hours, it will work. So then we can now start planning delivery. Next slide. Okay. There are some contraindications to expectant management. That is when we discover that, okay, this is severe preeclampsia, we want to buy time, but there are things that once they are discovered, just make sure that you deliver immediately. Persistent severe symptoms. So the blood pressure, well, we don't expect proteinuria to start improving or whatever, but one thing that is there is that once severe preeclampsia is diagnosed, it's a progressive preeclampsia on its own is a progressive problem. So, and if the symptoms became so severe, we cannot afford to continue expectant management. Then when there's multi-organ dysfunction, then no matter what decimal age, we are getting that. We have to deliver that baby. Then IUGR, that is below 5%, 50 percentile, because once it is like that, before you know it, IUF will happen. Then suspected placenta abruption, they are all calls for emergency delivery. Then non-reassuring fetal test. So method of delivery could be vaginal or cesarean section. It depends on how you have evaluated the patient, and the most important thing is we want to deliver through the safest and the fastest means that baby at least the patients will be okay. Then postpartum management. This is very important because eclampsia can occur after delivery. So we don't just look at it that we have delivered the placenta, we have delivered the baby, so let's go and sleep. No, the greatest risk of postpartum eclampsia is within the first 48 hours after delivery. So generally, once placenta is delivered, they will have said that, okay, the disease will rapidly improve, but it's not usually like that. Some people, especially those that have severe preeclampsia, before they start getting reversible thing, they will first of all go get worse before they start coming down again. So then when there is diuresis, that is, patient is already losing the accumulated water, then this indicates that the syndrome is resolving. Next slide. Next slide, please. Okay. The next one is eclampsia. Eclampsia is the development of single or severe episodes of generalized tonic-clonic, not chronic, please, tonic-clonic convulsion, which are not related to other disease conditions among women with hypertensive disorder during pregnancy. We should note that it may unexpectedly appear in patients with minimally elevated blood pressure, and that we now say no proteinuria. So let us not be deceived that the blood pressure is not high now, why it can still be eclampsia. So the exact cause is unknown, but the thing that is known is that there is cerebral ischemia and there is cerebral edema. There are 3 types of eclampsia: antepartum, intrapartum, and postpartum. The commonest is antepartum, which affects 53%, but the most dangerous is postpartum. The reason is because why is eclampsia happening after you have delivered the placenta? So when there is postpartum eclampsia, we should all be on our feet because it is the most severe of them. Then risk factors: Black and Hispanic race, young age, nulliparity, multiparous pregnant women with a new partner. Then on both cases, yes, because ordinarily, if patients are booked and they are properly managed, they are monitored, eclampsia should not happen because they will have been picked at the level of pre-eclampsia, then which one of the goals is to prevent eclampsia. Next slide. The management of eclampsia, this is a multidisciplinary management, and it is because it is more, the problem affects, it is a multi-systemic problem. So for patients to be well managed, it's supposed to be taken care of by the different specialists. But as we know that it's not everywhere you can have all of them on ground. So the general measure is to care for respiratory system. Once there's eclampsia, we want to clear wherever the patient is so that it will not injure them. You want to tilt the air down so that all the secretions, it will not aspirate secretion. Then tongue to be protected so that it doesn't bite and it does not block the airway. Then prophylactic antibiotics. We need to monitor the inputs and outputs very well. We use the urethral catheterization so that we monitor it strictly, because fluid management is a very important aspect of management of this patient. Then efficient nursing, inquired semi-dacro, maternal vital signs monitoring and fetal heart signs monitoring, very important. Next slide. Next slide. Okay. So the treatment, hello, doc, my slide.
Hello, Dr. Oladunjoye. We cannot see the slides anymore.
Slides.
Hello, ma. Can you see the screen, ma?
Okay. Yes, I can see the screen.
Sorry, ma. Let me go to where we are. Okay. Are we still here?
Okay, thank you so much. Yes. That's where we are. Magnesium sulfate is the drug of choice, and this has been it has been, in fact, before we got to this stage, it was a serious thing, using different methods to take care of eclampsia that were not working until 1998, that there's this magpie, the magpie trial, everything, and it was now concluded that magnesium sulfate is the drug of choice, and it has been working. There are two original regimens. We talk of Zuspan and Pritchard regimen. The Zuspan is the intravenous way, though the two of them have they have the loading dose of intravenous. So for Zuspan, the loading dose is 4 grams given IV, then 1 to 2 grams every hour until 24 hours after delivery or after the last peak, whichever one comes last. So then Pritchard, the loading dose is 4 grams given intravenously, then 10 grams divided into 5 grams each on each of the buttocks. That's the loading dose. Then followed by 5 grams every 4 hours to alternate buttocks until 24 hours after the last week or after delivery. There have been different modifications. Now, in Nigeria, we are looking at the alpha. Professor B.A. Ekede did a lot of work when it comes to this magnesium sulfate. You know, he was in the north, he's still in the north, and his work was mainly in the north. So they tried different ways of reducing the cost. In fact, it has been done to the extent of, even if it's only loading dose that is given, especially for those with severe preeclampsia, it is enough to take care of the patient, because they are trying to look at this. How is it that it will happen that, I mean, the cost will not be a serious thing. So his work, he has done a lot concerning magnesium sulfate use, magpie trial, he was part of them. Then in year 2015, there was this project, Ending Eclampsia Project, by Population Council. It happened between April and September 2015. Why are all these things still happening? It's because despite all the work that has been done, up to now, we still have patients coming down with eclampsia, not even pre-eclampsia, eclampsia. There was a study that was done. This study was a prospective study, not retrospective, so that they had 27 eclamptic patients in a teaching hospital. But what is there was that 25 of these people were unbooked. 2 were booked patients, 1 booked at an health center, the other one in the private, from a private hospital where they were referred. But we still have government hospitals, hospitals that are still having loads of eclampsia in this age. It's not a thing that should be talked about, because ordinarily these patients are supposed to be booked and they will have been picked up and then prevent eclampsia from the point of pre-eclampsia. So next slide, sir. Okay, so although many patients, many pregnant women with high blood pressure have healthy babies without serious problems, the high blood pressure can be dangerous for both mother and fetus. So hypertensive disorder is still a major cause of maternal and perinatal mortality and morbidity. Early diagnosis, prompt and appropriate management will go a long way to prevent the problems that can result from this. Healthcare facilities should be made accessible and also be patient-friendly so as to encourage patronage, hence reducing the number of unborn pregnant women. Necessary means of managing these patients should be made available at healthcare facilities. Prompt referral as it is necessary, training and retraining of healthcare workers, and education at the community level. All of this will help in preventing this scourge that we call hypertensive disease in pregnancy, especially preeclampsia and eclampsia. For the last category, that preeclampsia that is superimposed on chronic hypertension. They are all the management that we have eliminated. Thank you so much for listening.
Thank you very much, Ma. Thank you very much, Ma.
You're welcome.
Okay. Thank you very much, Ma, for the detailed and yet clear and concise presentation. It was very informative. We are very grateful, Ma. Once again, good evening, sirs and Mas. My name is Dr. Edemi, and for the last couple of minutes, we have been listening to our presenter. She's Dr. Similoluwa Albert. She's an obstetrician gynecologist at the Eco Hospital, Ikeja, Lagos. She's the typical, she has the double fellows, what we typically call double star general. She's a fellow of the West African College of Surgeons and also a member of the the National College of Surgeons in Obstetrics and Gynecology. She's a great teacher and a trainer, and she had been discussing and teaching us so far about hypertension in pregnancy. And so far, quickly, I'll just, within 2 minutes, just highlight one or two salient things she mentioned. She had told us about the classification into chronic hypertension, preeclampsia, gestational hypertension, and eclampsia. And one of the pertinent things she mentioned, which I think we should also not forget, she mentioned so many things. Concerning preeclampsia, she made us understand that it's a progressive disease. So whenever you have the severe form, you don't want to continue with the pregnancy. Unfortunately, you find patients, especially those remote from term, coming with the severe form, and you are now, as an health practitioner, you are torn between do you want to continue the pregnancy or not? However, it's not something you would want to do because it will keep getting worse. Then concerning eclampsia, she also mentioned that you could have an eclamptic patient with a minimally low blood pressure or a normal blood pressure, yes, with no proteinuria. It may not, the patient may come and you would think that, oh, I'm not having elevated blood pressure, so why would I term this as eclampsia? But it could happen. And she also made us understand that it can occur both antepartum, intrapartum, and postpartum, but the postpartum type is the most dangerous. So quickly, I would like us to entertain questions, sirs and mas, for our presenter. If you have any concerns, any questions, it's time to come up on board. You could write your questions in the chat box. You could unmute and ask your questions. Dr. Oladunjoye, sir. Hello, sir.
Continue, ma. Yes, ma. I'm following.
So can they unmute themselves and ask their questions?
Yes, they can unmute. Or they can also raise hand to make it more organized.
Okay, thank you, sir. So we can, if we have any questions, please let's just signify by raising our hands or write on the chat box. Thank you, sirs and mas.
There's a hand up.
Okay, so Olukunle Oluwatula, is it a doctor? Dr. Olukunle Oluwatula, please go ahead with your question, sir.
Thank you. I want to appreciate the doctor for the presentation. We appreciate it and it's educative. My concern is those that works in the maternity, especially maternity where you have people that they've been practicing delivery and all that for several years. I'm talking of the older generation of midwives now that probably would not have gone to formal education or gone through formal education. So how do you educate them about this issue that we're talking about now? Thank you.
Thank you, sir. I would like us to just take all the questions so that we can just answer them. Do we have more questions? Okay, in the absence of another question, Ma, would you like to go ahead with the question, Ma? Thank you, Ma.
There's one question. Okay, that the older generation midwives, especially in all these maybe health centers or whatever. Now, how do they get educated? One thing I know is that, like in Lagos State, I know that there's a big work that Sogon is doing, whereby there are consultants that are located into different health centers, such that they go there to go and oversee what is happening there, as if they are the ones that are helping to manage them. So, and such people, there are lectures, there are trainings that they give to them. In fact, we know that most of our patients go to all these maternity homes instead of them to come to maybe talking of bigger hospitals, government hospitals and everything. But anyone that is managing, that has things to be done with pregnant women, they already know the basic things. You have a patient that is coming for antenatal. Number one, you don't play with their blood pressure, you don't play with their urine test. And once there's any problem, you refer. Once we know our level, the stage at which we're supposed to send the patient to the next place where they can be taken care of, that will help a lot. In fact, apart from even talking of maybe people that this our old generation matron or health caregivers, there are some hospitals that you know that this patient has pre-eclampsia that is already severe, but you don't have the neonatal unit to take care of this baby. Immediately refer that patient before delivery to where they can take care of the baby. So it still come to this our training and retraining to let people know that these are the danger signs that you look for and you know the next thing to do with them. I don't know if I've answered that question.
Sir, are you satisfied with the answer?
Yes, I'm okay. But I'm also, maybe I should, what about the place of advocacy? Targeting these elderly midwives that may not find themselves in the school setting again.
Well, yes, actually, I mentioned something about ending eclampsia project. It was actually a big project with the Population Council and USAID. And what they did was they actually went into, their aim was to expand access to proven intervention for preventing, detecting, and treating preeclampsia and eclampsia. And that made them, they went into the health center that we are talking about, only that it was not every part of this country that they used. They just used six states in this nation. But the problem with us in Nigeria is anything that we see as free, instead of our government to now take over from there, when those that are brought it for us are going, when it has to do with money, that's just the problem. This advocacy, they are the things that will have helped to go into all those places and go and train these people, even when they don't want to move, you go and train them there. So that I remember when during it was even postpartum memory that we were trying to address when we were using this misoprostol or whatever. In the north, the people went to all those TBAs, those traditional birth attendants. They taught them that they gave them quantity of things that once this blood that the patient has pushed, if it has soaked this one, or you start moving, it's already postpartum. They did it up to that level. And that really helped in preventing all the problems that was happening with postpartum memory. The same thing in this pre-eclampsia, eclampsia. Advocacy will do a lot of things, but we can't force our government. They do what they want. Thank you.
Thank you, ma.
You're welcome.
Thank you very much, Ma. And also, in addition, what I know again is that apart from the enlightenment programs we give to all these people, the traditional birth attendants, maternity homes, we also have, we also give feedback. So when they come, when they refer their patients, or maybe the patient gets referred and, probably comes in a bad state and all, and after being treated and all, we tend to get a feedback to them, let them know about what the current state of the patient. So I think that also has proven to be helpful. Thank you very much, Ma. On the chat box, I don't know if this is related to our discussion. Someone wants to know, she says, thanks for the presentation, Ma. She wants to know about ginger herbal extract. Is there any role for the use of herbal extracts in the prevention or treatment of preeclampsia? I want to believe that, although the person is talking about arthritis and backache here, but today we are talking about hypertension in pregnancy.
There is another one that was saying, can an expectant mother take ginger herbal extract? Well,
okay, so maybe you have to comment on that.
Yes, one thing I will just tell us, all these herbal things, you should be very careful about them, especially when you are pregnant. You can take it as a person and it will not do you anything, but that baby in the womb will not tell you that, this thing is too harsh for me. So as much as possible, it is better we avoid using those things. I usually say that all these, our tablets and everything, they are made from herbs and roots, quite all right. But, there's a way they have been made into dosages. There are ways that they have removed things that are toxic, things that can harm our organs there. But all these things, when you are now combining this with the one that they are giving you in the hospital and everything, we don't know when you are taking over those. We don't know when you are taking things that are risky for the baby. But what is there is that, for malformations or whatever thing, most of us don't even, most people don't even know their pregnancy has not been diagnosed before most harm has been done to the baby. Because by the time you are making diagnosis that yes, you are already pregnant, maybe you say you are 1 month pregnant, your 1 month pregnancy is already 2 months, and the most important aspect of the baby has been formed. So if you have used things that is harmful, it will have already caused problem for the baby. So it's better we just avoid taking all these other things in pregnancy. Thank you.
Thank you very much, Ma. I don't know if we have more questions concerning hypertension in pregnancy. Questions, concerns, things we are not too clear about, so that they can be addressed.
Thank you very much, Ma, for moderating the event today. And thank you also all of us that joined early. We actually started, and some people are joining now, thinking we are starting by 8, started by 7 as advertised, because running to late night. That's why I felt at this time let's do it early so that we can finish on time. And I'm sure we have learned one thing or the other today. And those of us that came later, we can watch it on the YouTube, so that whatever question we have, we can pass it on. We can be answered directly to us. We can pass our questions on. We can. Today, in commemoration of the Mother's Day, we've chosen to talk about this important factor that affects women, and I'm happy that our lecturer talked about increasing rate of older age people with pregnancy, which is becoming commoner in our environment. Recently, I saw a 55-year-old, 50-year-old. This one was even 55-year-old delivering a triplet, IVF conceived with attendant issues. So this thing has become more prevalent in our environment. And like she has said, maybe another thing we need to also do is that thank God for all the women that are here to do more advocacy on women to be able to prioritize childbirth in their as they plan their life, so that at least these things should be done when the body and everything is still fit for it, rather than when it's going to come with a lot of attendant problems. Hypertension is becoming more commoner in younger people, and in pregnancy, we can see from today's lecture that hypertension is a problem in pregnancy, which as much as possible we want to prevent, and we want to also avoid. And when present, we want to treat as soon as possible with the best effort. And like it has been said, once these things are there, we need to be sure we are registered. Like in response to the question that our Mr. Pastor Lukunle asked, we need to always advise these women, especially in churches and mosques and everywhere we are. People that are having pregnancy at older age for the first time, somebody 32, 33, 34, 35 is having first pregnancy. Those are not the kind of people that just go and register in the maternity home or somewhere where there's no expert that is monitoring. We need to advise these people to, even though they register on these people, they should also register in government hospital where available facility can be available, and the things can be picked up early and they can be helped, because it's not nice for a woman to have carried pregnancy to 8 months, 9 months, eventually had a eclampsia before they could get to anywhere. The woman is gone, the baby is gone, the father body is, and then by the time you get to these places, it's difficult to help them. Then there's stories, the hospital have killed my wife, this I've done, that, not knowing that they also themselves have not done what they're supposed to have done to be able to get better outcome. So thank you very much for attending today. We look forward to another exciting topic next month. Thank you very much. This will be the end of today's meeting. Thank you all for attending.
Thank you.
So I will end the meeting now. Thank you very much.